Hi, my name is Jonathan Sembrano from Minneapolis, Minnesota, and I'm here to talk about spinal stenosis. What is spinal stenosis? Well, as you know, the spinal column is made up of many bones stacked on top of each other. Each spinal bone or vertebra articulates or connects to the next bone above or below it through 3 points of articulation: the disc in front and the two small facet joints at the back. Now, these points of articulation could develop degeneration or arthritis as one ages. And the changes that accompany these could eventually lead to narrowing of the canal. The canal contains the spinal nerves, and narrowing could cause nerve pinching. Now, the canal is also lined by a ligament called the ligamentum flavum. And as the space between the vertebrae shorten or collapses, then the ligament could also shorten or buckle and become relatively thicker. This further contributes to the spinal stenosis or the narrowing. What are the symptoms of spinal stenosis? The symptoms of spinal stenosis relate mainly to the nerve pinching or compression. Now, if only one or two nerves are pinched, this may produce a very distinct pattern of pain, numbness, or tingling down the leg that we call radiculopathy. If more nerves are affected, then the distribution may become more diffuse or less well-defined, and we term this as neurogenic claudication. And patients may describe this in a variety of ways. They may present either as low back, buttock, thigh or leg cramping or numbness or weakness or pain. But what is important is the pattern as to what aggravates and relieves it. Generally speaking, neurogenic claudication from spinal stenosis is aggravated by standing and walking and relieved by sitting or leaning forward, such as over a shopping cart, what we call a shopping cart sign. Laying down may also improve symptoms by elimination of gravity. However, laying down flat on one's back simulates standing upright, so most of the time patients prefer to lay down with their head up, such as on a recliner. So for diagnosis of spinal stenosis, we always start with history taking and physical examination, and then we confirm our diagnosis with imaging modalities. This typically includes advanced imaging modalities, such as an MRI or a CAT scan, either a plain CAT scan or one with a myelogram that we call CT myelogram. It's also important to take upright X-rays to evaluate alignment and ensure that there is no instability that may only be noticeable when one is standing. We also have to remember that spinal stenosis as a degenerative condition becomes more common as people get older. Unfortunately, this age group also becomes more prone to other disease conditions that may produce symptoms very similar to spinal stenosis. So it is important to distinguish one from the other. These may include vascular claudication from atherosclerosis or peripheral neuropathy, the most common cause of which is diabetes. Ancillary studies such as EMGs or electromyograms or vascular studies such as with Doppler or ultrasound may also be necessary in order to differentiate spinal stenosis from these other conditions. As with all degenerative conditions and most spinal conditions, the first-line treatment for spinal stenosis is non-operative. These may include activity modification, non-steroidal anti-inflammatory medication, physical therapy, exercises, and also injection procedures. These injections may consist of either anesthetic and or steroids and may be injected into the muscles or ligaments around the spine or into the spinal canal itself, what we call epidural injections, which would be around the nerves that are being pinched. For patients who do not respond to non-operative treatment, surgery may then be a reasonable consideration. The goal of surgery would be to decompress the spinal canal, or in essence, to take the pressure off the spinal nerves. This procedure is conventionally done through an open midline approach, and we unroof the spinal canal, a procedure that is called laminectomy. We also make sure that the nerves are freed at the openings where they come out, what we call a foraminotomy, which is enlarging the foramina. Now, this has to be balanced with not making the spine unstable. So taking a lot of bone out could cause instability. And so the challenge is to achieve adequate decompression without causing instability. There are also other ways to achieve the same decompression through less invasive approaches, either with tubular retractors or with endoscopic approaches. But the goal is to still be able to achieve the same amount of decompression while reducing the approach-related morbidity. In patients who present with other spinal conditions, such as instability or spondylolisthesis, or severe deformity, a fusion may become necessary. If a fusion is performed, it adds to the morbidity of the procedure, to the length of the procedure, and generally to the blood loss. These would include placing screws into the spine, with or without placing cages, and placing bone graft. The bone graft could be harvested either from the iliac crest or by using cadaver bone or allograft bone. All these options would be discussed with you by your surgeon. Typically, the hospital stay is shorter if one does not have to do a fusion versus if a fusion is performed. Also, the hospital stay could be shorter if one undergoes a minimally invasive decompression versus a conventional open decompression. That said, different patients may have different levels of deconditioning coming into surgery, and other factors, including medical comorbidities, may also play a role. Patients who are very deconditioned heading into surgery may take some time before being able to recover their function, and these patients may benefit from a short stay at a rehabilitation facility. Other variables, including resumption of driving or having to wear a brace, should probably be best discussed with your individual surgeon, as there may be variabilities on a case-to-case basis.